presentation, slide deck, and a lot of other resources as well. To minimize distractions, please keep your microphone muted and camera off unless you're presenting or we are in the discussion phase and you want to say something. And for accessibility, closed captioning is available in the Zoom settings. Next slide, please. So welcome everyone. My name is Farhan Yusuf. I work with FHM Engage and I am the lead moderator for the Healthy Markets Community of Practice, which is co-chaired by USAID, represented by Andrea Baer, and UNFPA, represented by Ben Light. This community of practice is an evolution of the Total Market Approach Technical Working Group, which has been operational since 2014. For those who might be joining us for the first time, our goal is for our meetings to be dynamic and interactive and to facilitate more connections around market development and private sector engagement, specifically for FP and SRH. The goal is to share work amongst partners, working to increase the utilization of health services from the private sector. The session today is particularly interesting because for those of us who remember, we also used to have a pharmacies and drug shops technical working group, which at some point last year we had folded into this particular community of practice. And so every year we try to have some sessions highlighting specifically pharmacies and drug shops as a private sector outlet and channel for providing FP and SRH services. And we hope to have a lot of interesting discussions around that today. Before we go on, I'd like to invite Andrea first and then Ben to provide us with some opening remarks. Welcome, Andrea.
Okay, thanks, Farhan, and hi, everyone. I'll be super quick just to say hello. I think I know many people, and great to have this turnout today. I'm Andrea Baer, and I'm the AOR team for the FHM Engage project, and always appreciate working with Farhan, Dunya, and the FHM Engage team. And all the presenters that we have each time, and as Farhan mentioned, this one is a bit different because we're going topical rather than country oriented. And so we'll be interested to see how this goes. And there are also, there's certainly the possibility of a follow-on session related to, drug shops and pharmacies, because we always strive to have several speakers, but there's never enough time to have as many speakers speak for as long as they would like to. And Farhan will probably preview some other things going forward, but I would just say that from a private sector standpoint, obviously, I think we all share a significant interest in the role of pharmacies and drug shops in providing information, products, and services across all the countries that we're variously working in to improve that access. So I think to some extent today, we're really hoping to focus more on the aspect of policies and rules and regulations at country levels that impact the ability of these providers to deliver services and information. And of course, that does vary by country. And we realize all these things come together to make it possible for high quality services and products to be delivered. So looking forward to a great discussion, and either over to Ben if he's on the call or back to you, Farhan. Thanks.
Andrea, thanks a lot. Farhan, thanks a lot. Colleagues, wherever you are, big welcome. Really a pleasure to be partnering with Andrea and USAID on this and working with all of you. I'm not going to repeat what Andrea just said, but certainly echo what she just said. I just one thing that caught my ear, I suppose. Yes, I'm very interested to hear about the policies and the rules and regulations, but also to understand from your angle, closer to the ground, what's working, and to understand what we can do to facilitate improvements as you feel would be appropriate. Without further ado, I'm going to hand back to Farhan. I'm really excited about this session. I'm sure I'm going to learn a great deal. Thanks to all of you. Farhan, back to you.
Thank you so much, Andrea and Ben, for those opening remarks. We now have our agenda presented to us. We've just done our opening remarks. We'll start off by me providing just a little bit of a technical framing around some of the discussions we will have today. Then we are going to have 5 presentations from different speakers, and then as always, we'll jump into our discussion and Q&A, and then our closing remarks. Again, a reminder that please, as the presentations are ongoing, feel free to share your thoughts, ideas, questions, etc. on the chat so we can maybe make it a vibrant discussion. Now, next slide, please. Just a very brief sort of technical framing, and as Andrea mentioned, I think for all of us who work or are interested in working in the private sector, we do know that pharmacies and drug shops are very important outlets when it comes to especially last mile delivery in many of our countries for a lot of different products and services, but specifically FP and SRH because of various reasons, access, comfortability. Many of the personnel at these pharmacies and drug shops are usually young people, so there's a youth angle, there's a comfort there, etc. And so there are various reasons, right? But I think in many of our countries, we see that pharmacies and drug shops are usually quite limited in terms of policies, rules, and regulations, as mentioned previously by Andrea, that sort of limit them from achieving their full potential, right? So we thought it would be nice to sort of start with some sort of framing. I was going through a lot of different documents online that talk about this, and this particular diagram caught my eye, and it is part of a thought leadership paper that was done by the Global Health Supply Chain Project called the Use of Retail Pharmacies as a Source of Essential Medicines, including FP products for public sector clients in low and middle income countries. We'll make sure we share this out as part of our resources in the newsletter for this session as well. And I think, although it focuses on pharmacies, I think the principles are very similar to drug shops as well, in that we really want retail pharmacy service delivery to be accessible, affordable, of good quality, acceptable, and financially viable, right? Like these are all things that we want the products and services that are delivered through these retail outlets to have. However, there are certain surrounding sort of factors that we need to think about, many of them related to rules and regulations and policies. We have aspects around human resources, for business, health, and public services, where we need to think about, are the policies allowing the right kind of people to be at the pharmacies and drug shops, or are they limiting them? Are we having the right kind of financial incentives to retain the qualified human resources? How exactly are we training and building capacity? Are there policies around there? I think in implementation, we see that in many of our countries, it is, whenever we are rolling out trainings, the priority is given to the public sector facilities, even though we know that many communities are accessing these products from these private sector outlets. So what are the policies that are around that in terms of task shifting, right? Are we allowing pharmacies and drug shops to do which is truly within their capacity so that the communities get the kind of services that they want? When it comes to markets and supply chains, are we enabling these pharmacies and drug shops to use the right technologies to improve their supply chains? Do we have the right kind of procurement policies to support them? When we are doing things like insurance, health financing, are we including pharmacies and drug shops in that as well? We also have to think about access to finance. Do we have the right kinds of policies in place that support pharmacies and drug shops to be able to access financing, from maybe the government or from banks, financial institutions, be able to, negotiate deals with large wholesalers, and then just generally in terms of, effective governance, there are data concerns, like how are we enabling pharmacies and drug shops to share data? There are, supervision, guidance, etc. Do our policies support pharmacies and drug shops to be able to get those kinds of facilities either between themselves or from the government? And then there's also some things that are not mentioned here. For example, Marketing is another challenge. In some of our countries, pharmacies and drug shops may not be able to market particular products, particular services, or just generally. So there's a lot as far as policies, rules, and regulations is concerned that needs to be in place so that we can truly unleash the potential of these pharmacies and drug shops in being able to provide family planning and sexual and reproductive health products and services. And we hope that with the presentations today, we will be able to see some of the country examples where some of our partners have done work in terms of promoting, some of these policies, guidelines, etc. So that is the learning we are expecting today. I do know that we also have some participants who may not have been able to get a presentation through, but I had asked them to please share their experiences when we get into the discussion as well. So without taking much of time, I think we can move on to our first presentation for today, which is not exactly a country example, but we felt this is something important for us to sort of, I know we had tried to do this last year as well, but due to availability, it was a challenge, but we felt it would be nice for us to find out a bit more about the pharmacies and drug shops high impact brief. So Dr. Vineet, if I can ask you to please come on and take us through this first presentation for the day.
Thank you, Farhan, and good morning, everyone. It's so nice to see and meet Andrea and Ben Light after some time. Ben, I hope everything is fine. Well, without wasting time, I know that we are really short of time. So I'll start with the next slide, please. The high impact practices, or HIPs as we call them, for family planning are a set of evidence-based family planning practices that have been vetted by a group of international experts against specific criteria. HIPs were first created in 2010 with the task of identifying a list of practices that, if implemented at a scale, would help countries address the issues of unmet need and contraceptive prevalence. HIPs have been identified based on demonstrated magnitude of the impact on contraceptive use and potential application in a wide range of settings. Next slide, please. There are three types of, or three categories of HIPs: enabling environment that address systemic and policy issues, service delivery that improve access, availability, acceptability, affordability, and the quality of family planning services, and social and behavioral change that address socio-cultural, behavioral, and personal factors. What we see here is also enhancements. HIP enhancement is a tool or approach that is not a standalone practice, but is often used in conjunction with some HIP to maximize the use of the HIP implementation and increase the reach and access for specific audiences. Pharmacies and drug shops is a service delivery HIP. All HIPs are available in English, French, Portuguese, and Spanish. Next slide, please. All HIPs are supported by over 65 organizations. There is a technical advisory group that ensures high technical quality of the key HIP products and approves HIP briefs and concepts for development. There is a technical expert group that are tasked with writing new HIP briefs and ensure that they are up to date. You can see the list of the co-sponsors on the screen. Next slide, please. Varun, I have promised to be on time, so don't worry. I'll try to keep my time. The high impact practices on pharmacies and drug shops is a brief that deals with the importance of these outlets for providing commodities and information, and outlines key issues for planning and implementing programs to support pharmacy and drug shop staff. While many pharmacies and drug shops already provide family planning services, This HIP focuses on how to strengthen and improve these services and their impact. You know, in all the countries, even in the remotest of the villages and remotest of areas, you might have clinics, but these clinics are often facing a shortage of staff or stocked out. Well, you will find a pharmacy or a drug shop which never has these problems. And these are the places which have the confidence of the community. Next slide, please. As you all know, private sector pharmacies and drug shops are often the first line of healthcare in low and middle income countries, particularly for many underserved populations, and especially in remote, rural, and tribal areas that have very few private or public clinics. Pharmacies and drug shops, with their convenience of timing, anonymity, and cost savings compared to private clinics, can be an essential source of health service, products, and information that is particularly important in the context of frequent stockouts I just mentioned in clinics and health worker shortages. Evidence has shown that with training and support, pharmacies and drug shop staff can facilitate the use of a broad range of modern contraception, especially in areas where various socio-cultural barriers prevent women, men, and young people from accessing family planning services in the clinics. Next slide. This slide, I hope you can, I don't know how to enlarge it, but this slide presents the theory of change in details. And because of the paucity of time, I'll not go into those details here. You can go through the slides at your own leisure, but they identify barriers and how the high impact practice can be used, and then service delivery changes, benefits to the clients, and the outcomes and impact. Next slide, please. Why is this practice important? As I told you earlier, studies in many parts of the world have already shown that clients often find drug shop operators more friendly, more acceptable than public sector clinics and staff there. Pharmacies and drug shops also offer clients proximity, flexibility in operating hours, and responsiveness to client needs compared to public sector clinics. Another issue that is important here is anonymity. You have to go register your name, your address, your partner's name, I don't know, so many details, your personal details in a clinic. Whereas in a pharmacy, everything seems to be anonymous. Supporting and strengthening pharmacies and drug shops is an effective way to complement the public sector. They're not alone. They're not working alone. They're actually complementing the public sector, and they expand the impact of the health sector. Implementing these guidelines will require policy change, which has already happened in a number of countries. Next slide, please. What is the impact of this brief? First, let's talk about access. As I mentioned earlier, pharmacies and drug shops are already an important source of supply for a range of contraceptives in many countries. Actually, as many as 80% or more of condom users obtain their methods at pharmacies and drug shops, with a growing proportion of injectable users and almost 50% of pill users. Pharmacies and drug shops are also popular for short-acting contraceptives, such as short-acting contraceptives for unmarried women, men, and young people, due to convenience, cost, and confidentiality. Young women who are often single, who fear stigmatization in family planning clinics or outlets, increasingly source their contraception from drug shops and pharmacies. Drug shops are also convenient for men and boys who are less willing to go to clinics, especially the government clinics. Next slide. Impact on the quality. Training and support to the pharmacy and drug shop staff can really improve the quality of family planning services and information being offered there, and thereby improving client satisfaction. With training and supportive supervision, pharmacy and drug shop staff generally provide family planning services safely, reliably, and with greater client satisfaction. I don't know how many of you have this experience, but in clinics, in government clinics, supplies could be dispensed for a period of 1 month, 2 months. There's always a limit. Here, there's no limit. You can go once and buy your supplies for 6 months, 1 year, depending on your availability of funds and your needs and your convenience. Social franchising and social marketing have also helped expand the role of private sector pharmacies and drug shops. This is important here. You're talking about social franchising earlier, in increasing access to a range of contraceptives and also play a role in improving the quality of services there. Pharmacies and drug shops is regarded as a promising practice. It is still regarded as a promising practice, thereby implying availability of limited evidence with more information needed to fully document this practice as an impact. Next slide, please.
Dr. Vineet, if we can summarize, and I think later on, in the chat or in the discussion, we can talk about how to actually use the brief to sort of improve.
Okay. If you want to, there are 2 more slides. Let's forget about them. I was a member of the group that framed this brief, and the question usually was how to ensure quality and how to ensure that the staff, because the problem there's high staff turnover. So these were 2 issues that we had identified as challenges, but then there are ways and there are means that can be implemented at the policy level to overcome them. Finally, on a lighter note, Farhan and to everyone here, I was once asked that this name HIP, is a bit funny. And why did they come up with this name HIP, this abbreviation? The answer is a very simple one. As a medical doctor, I can tell you, the body moves only because of your hip. If there's no hip, the body is stationary, the body is stable, and you are doing nothing. So if you want the family planning program to move and to achieve higher goals and higher heights, hips are important. Thank you so very much.
Thank you so much, Dr. Vineet. I think we really wanted to highlight the HIP as a tool that can be used to improve practice. And as I said, I hope we can have more discussions on how exactly the HIP can be used to promote some of these practices. So thank you so much. Moving quickly to our next presentation, which is from SFH Nigeria. Mike, I know you're online, please.
So good afternoon, all. It's nice to be here. So I'll be talking about overcoming policy and regulatory barriers for family planning uptake among community pharmacists and patient medicine vendors in Nigeria. We are sharing experiences from the Gates-funded Integrity project. Next slide. So a quick outline. So first we'll define who a community pharmacist is and who a patent and proprietary medicine is in line with the Pharmacy Council of Nigeria guideline. Then we'll look at our situational analysis. We'll talk a little bit about the PCN tiered accreditation, and then we'll share an overview of the Integrity project, phase 1 of the project. And then we'll talk about our strategic approach to policy change and some of the challenges we encountered, and then we'll have time for questions and answers. Next slide. So, according to the Pharmacy Council of Nigeria, that's the body responsible for regulating community pharmacists and patent medicine vendors in Nigeria. A community pharmacist is a graduate of pharmacy, and they are permitted to stock and sell all medicines, including poisons and prescription drugs, as well as over-the-counter. But based on the guidelines and the policy in country here, community pharmacists are not allowed to provide injectables. In fact, they are not allowed to provide any form of injection. So for family planning injectables and implants, the law prohibits CPs from providing those services. For PPMVs, that's a patent proprietary medicine vendors, these are persons that are not pharmacists, but they sell orthodont medicine for profit. We see some of the requirements. They must be 21 years and above. They must have some form of education, first school living certificate or secondary school living certificate. And they are permitted to stock and sell only over-the-counter medicine. And they are not allowed in any way to provide injectables and implants. Next slide. So the current situation on ground, like I said, is that the CPs and the PPMVs are both regulated by the Pharmacy Council of Nigeria. In Nigeria, we have over 8,500 PPMVs and over 8,500 community pharmacists and over 200,000 PPMVs. The PPMVs are mainly in rural and semi-urban areas, while most pharmacists are found in urban areas. There are private for-profit businesses with little or no government support. And like I said before, they are licensed to stock both prescription and over-the-counter medicine, while the PPMVs are only allowed to sell over-the-counter. So for the situation on ground, both the CPs and the PPMVs, they are not allowed to provide injectables and implants. Next slide. So in realization of this, the Pharmacies Council of Nigeria started around 2016 after a learning visit to Tanzania and came up with the concept of tiered accreditation system based on realization that the PPMVs are not a homogeneous group, that group is heterogeneous. And in that cadre, there are different cadre of people. So based on that, the PPMVs were classified into 3 tiers, with tier 1 being the the lowest level of service providers, just ability to read and write, school certificates, and mainly are not health workers in any way. Then the tier 2, there it was also realized that about 30% or thereabout of all PPMVs do have some form of health qualification. So that was a very good insight. And most times that qualification centered around nursing, midwifery, as well as community health extension officers. Then there is also another group, the tier 3, which is a special cadre created by the regulator. And these are pharmacy technicians. Next slide. So in phase 1 of Integrate E, which started in 2017, it was a proof of concept, just a pilot in 2 states in Nigeria to test the concept that the community pharmacists and the patent medicine vendors can provide a wider range of FP and PHC services than they are currently authorized to provide. It was funded and is still being funded by the BMGF, but that phase 1 also had a co-founder, MSD for Mothers, and it was in just 2 geographies, Lagos and Kaduna. The primary targets were low wealth quintiles living in underserved area of Lagos and Kaduna, and the partners were SFH, the lead partners. We have the Planned Parenthood Federation of Nigeria, we had Maria Stopes, we had Population Council, and we had pharmacists. And the project had 3 key objectives. First was to create a supportive operating environment for family planning provisions among CPs and PPMVs in Nigeria. The second was to strengthen service provision among this group of providers. And the third was to implement a learning agenda to generate evidence that will inform policy change. Next. So what was our strategic approach? So over the last 7 years, we have gone through some stages in arriving at where we are currently. When we started in 2017 for the pilot in those 2 states, the law didn't allow CPs and PPMVs, and as is to offer those 2 key services, the implants and injectables. So we have to obtain special waiver from the regulator for those providers that we enrolled into the project. And in Lagos, we had about 500 CPs and maybe another 800 PPMVs. We had about 200 CPs in Kaduna up north and close to about 600 PPMVs. So we have to obtain special waivers from the regulator, the Pharmacy Council of Nigeria. And because health is on the concurrent list in Nigeria, we also had to go down to those state governments in Lagos and Kaduna to obtain, riding on the waiver from the council, to obtain an extension of that waiver in the states, just applicable to the cohort of providers that we have enrolled on the project. And that allowed those providers to offer implants and injectables. So the next step was for us to develop a training curriculum for the CPs and the PPMVs for the long-acting reversible methods. We then proceed to train the selected providers, as the CPs and the PPMVs, and then we mapped them to the public sector facilities, the primary healthcare centers, proximate to where they were situated, to provide referrals for those services that they could not offer, especially the IUDs. But the PHC centers also served as centers for competency training, because after the training in the classroom, they are also expected to meet some minimum standards, which includes ability to provide about 12 insertions for the implant and 3 removals to be satisfied as competent and proficient. So they needed to undergo that after the classroom training in the PACs. So we had to also work hand in hand with the public sector at that stage. Then the 3rd stage was also to set up a project steering committee at the national level. It was headed by the director for RH at the Federal Ministry of Health, and also co-chaired by the registrar of the Pharmacy Council of Nigeria, to provide guidance and oversight, governance oversight over the implementation period. We also strengthened a state-level committee called the PPMVL committee. We worked with that committee to provide integrated supportive supervision on a quarterly basis, in addition to the routine supportive supervision that the project was providing. So for the stage 4, the learning agenda kicked in at this stage, and then we were able to generate enough evidence after from a year or 2 to now present. We shared those evidence with the RH Technical Working Group, as well as to key stakeholders like the Federal Ministry of Health and the PCN. So based on that, we were able to revise, we were able to get enough buy-in for a first revision of the TFTS policy. That was in 2018, and then relying on further evidence in 2022, we were able to get the final revision that eventually allowed CPs and PPMVs to offer implant and injectables in Nigeria. So next slide.
Michael, if we can summarize the next slide, please.
Okay, next slide. So for us, the policy win has been the revision of the tax system steering policy, the 2022, which is the 3rd edition, and that clearly recognized CPs and PPMVs as providers of implant and injectables. So we have also developed, worked with the federal ministry, the government, the public sector, to recognize this set of providers as key providers in the National Strategic Framework for Community Health in Nigeria. We were also able to work with the PCN to revise the approved patent medicine list to include injectable contraceptives like DMPSC. And then we have supported the CPs and PPMVs to report service provision into the public sector community health management information system. And so next slide. So this is just a summary of the scope of service that the law, the guidelines currently allows PPMVs and the CPs to provide. So for the tier 1, you can see for tier 2 and 3 and the CPs, they are able to provide injectable contraceptive and implant at this stage. The TSTS policies, based on the evidence that has been generated, has allowed that to happen. So next slide. So what were some of the challenges and the learnings? So there were initial pushback from professional group, particularly Association of Community Pharmacists of Nigeria and the larger Pharmaceutical Society of Nigeria. And there are also the need to overcome the perceptions that PPMVs were providers of suboptimal, poor quality services. And thus, the regulator were reluctant to approve waiver for the initial pilots. A lot of advocacy work had to go in at that stage. And so what were the key learning? Advocacy had to be continuous during and throughout implementation. Then each of the stakeholders, not only regulator, must be engaged and their concerns identified and addressed. So one key thing for the success was also the fact that we always say the council was on the driver's seat. So these projects were essentially implemented by the Pharmacy Council of Nigeria with the support of the Federal Ministry of Health. They were always in the forefront of implementation. And then generation of high quality evidence from research was crucial in addressing some quality related concerns by stakeholders, including the Pharmacy Council and the PPMVs. And eventually, we had the policy change taking place. So next slide. That's it. Thank you, and we are open for questions and answer.
Thank you so much, Michael. And there was so much here to learn. I feel, from the tiering of the PPMVs, which I find quite interesting, to the steps that you outlined, which I think are very helpful in all of us to think about how that advocacy should be done, and something about the role of associations as well, which I would love to discuss at the end. Moving to our next presentation, Mercy, please take us through.
Hello, everyone. I hope my voice is clear.
Yes, Mercy, we can hear you.
Okay. So we are Mitch Investments Limited, established in 2009. Sorry. Mitch Investments portfolio consists of Mitch Pharmacy, which is a retail pharmacy business with 3 outlets in Lilongwe, the capital city of Malawi. We also have Gateway Pharma, which is a wholesale pharmacy, mainly feeding into the 3 retail pharmacy outlets. Then we also have a medical waste disposable facility, which currently is the only privately owned and licensed medical waste disposal facility in Malawi. Our staff complement is 30 full-time employees. Next slide, please. I will talk mainly about Mitch Pharmacy, considering that that's what is relevant to this discussion. So as Mitch Pharmacy, we provide various family planning products and counseling to our clients. The family products that we supply are sourced locally from private wholesalers and also from social enterprises such as PSI and BLM, that's Banjalam Tsugolo, under Mary Stopes Foundation. We also source on our own regionally within the SADC region, and also internationally from Europe. We have one product supplied to us by Ministry of Health at the moment. That's the DMPA SC, which comes at no cost. However, we are required to charge 1,000 Malawi kwacha, which is approximately 50 cents service fee to the client. Of the family planning products that we sell, male condoms and emergency contraceptive pills are our fastest moving products, as you will see on the next slide. So if you check there, you see I've just extracted that from one of our retail pharmacy outlets, just one branch. And that sells volume from January to November 2024. And you notice that we sell a lot of male condoms, followed by emergency pill, which is just slightly below, 50% in terms of the sales volume. And then microgynon. You also notice that there are other products there, like Yasmin pills, that we import because there is demand for these from our clients. The Sayana press, we have it, but since June, end of June, from the Ministry of Health. That's when they started the rollout to us. But unfortunately, up to now, we've not been able to administer a single dose. Next slide, please. The challenges that we are finding in provision of family planning services, generally, I think the fact that family planning products such as the microgynon, the DMPA SC, and also others, they are provided for free in the public sector. And knowing that in the private sector, we provide products and services at a cost in order to make profit, it becomes very difficult for us to push some of these products that are available for free in the public sector. As you might have seen with the DMPA SC, we are still struggling to be able to push that. The microgynon, yes, we do sell it for those clients that want a fast service. But generally, if they are able to wait in line in the public sector, they would prefer to go and get it for free there. The other challenge that we face is the acute shortages of family planning products in both the public and the private sector, including even from the social enterprises such as PSI and BLM. There are times when other family planning products are not available, and it becomes very difficult for us, and we turn away clients. In the private sector as well, at times we find shortages, due to different reasons. And currently in Malawi, we are facing a forex shortage with wholesalers to import products. So another challenge is lack of awareness by potential users. That it's another challenge that we are seeing specifically with the DMPA SC. most of the potential clients, they are not aware that it is available in pharmacies, and they still continue to go to the public sector, and there's also lack of adequate resources to effectively equip the pharmacies to provide the FP services. We had the training through MOH and Banjalam Tsogolo for the DMPASC, and then we were given the Sayana Press, the DMPASC. So after we're given, we have noticed that we were not provided with the consumables, the medical supplies that we need, such as the cotton wool, the gloves, the sharp boxes, for us to be able to administer. So because we do not have even the soap, we do not have this. We highlighted this as well because for us now at 50 cents for us to be able to use our own supplies, it becomes difficult from a business perspective. So that's another challenge. Lastly, I would want to highlight that also the limited range of FP products on the local supply market makes it a challenge because we find that there are clients coming to us specifically, they want to procure the hormonal intrauterine device so that it can be administered for them in the private clinics. We also have demand for such products as Yasmin, Diane 35 from those clients that are able to afford. So yeah, those are the challenges in summary that I could manage to share. Next slide, please.
Thank you so much, Mercy. If you can summarize, please.
Okay, thank you. So you find that just before I move to that last slide, you find that only one staff member in all our 3 branches has been trained to administer the DMPASC, which we also find as a challenge because it becomes difficult for us because we only have one person who has been trained, and that same person has to move across the branches, which is obviously impossible. And another issue is we also have to consider if we are charging 1,000 kwacha, which is 50 cents, from a business perspective, to say, okay, how do we release most of our staff to say, can you please go to the nearest government facility for training? Because for us, we are also looking at the time that it will take against, the benefit that we would get from those employees if they stay within the branches. So in terms of activities or interventions that we have seen so far, it's the rollout that I've been talking about of the DMPASC in the private pharmacies. But I feel that there is need for more medical consumables, not more, but for us to get the medical consumables, more staff to be trained, sensitization also to the public of the availability of the DMPASC in the pharmacies, and then also to develop a proper business model which could be attractive to the private sector, such that as a pharmacy or as a private business, it would make sense for us to recommend DMPASC when we have other family planning products that could also, in the long run, give value to what we are doing or help us in terms of meeting our overheads. So another intervention would be a consistent supply of FP products, because at times we go for months without some of these FP products. I remember this year we had dry months of no microgynon on the market, because microgynon we normally get it from PSI and also from private wholesalers, but we were failing to find this product from both PSI and also from the private wholesalers. There's also need to increase range of available products to the private sector players. We wish the government could consider, because we know that there's economies of scale when the government is procuring. If there was a way that the government could also procure, these family planning products, probably brand them in such a way that there's a difference between what is meant for the public sector and what is meant for the private sector, then we can be able to procure as the private sector from the public sector, which obviously could also help in terms of the government raising public revenue.
Let's see if we can summarize, please.
Okay, lastly, the government needs to support in creating an enabling environment for FP services in the private sector. Collaborative relationships should be forged as well with social enterprises, as we notice that at times they also have other programs that they are running, but would love to have stronger relationships with the social enterprises. Then licensing of more FP products by the regulatory authority. Next slide, please. I hope there isn't anything more. Okay, Zikomo, that's how we say thank you in Chichewa in Malawi. Thank you.
Zikomo, merci, and thank you. Yeah, you will see a lot of questions in the chat for you. I guess this is what happens when we finally get a voice of the private sector implementer themselves, the pharmacies. Thank you so much for representing that group. Moving quickly on to the next presentation. Elsa, are you online?
Yes, Haran. Good day, everyone.
Yes.
My name is Elsa
Hey, Elsa,
Nyantum.
please
I
go
work
ahead.
for PSI Mozambique. I'll switch off my video to improve the signal. Next slide, please. Okay, so these are the outlines of the presentation. We'll present on the overview of the projects, the challenges, same as my previous colleague presented on their countries, and the approach that we use to mitigate or to overcome these challenges. And we will also share lessons learned during the implementation of the projects. Next slide, please. So the MPHD has the aim to decrease maternal, newborn, and child mortality and morbidity by enhancing access and utilization of high-quality, evidence-based information, services, products through a private healthcare providers. We support the 54 private facilities, and in the case of this presentation or meeting, we will highlight the work with the 28 pharmacies. We started in June 2023, and we are closing now in December. We work in one of the, in North Mozambique, in Nampula province, which is the, in terms of population, it has the majority of the population of the country. And typically in Mozambique, pharmacies are frequented by low to middle income clients. They are positioned closer to the communities, and they generally don't offer counseling services. Next slide, please. These are the challenges that the private pharmacies face in I would say in Nampula. outdated regulatory framework for private pharmacies. This is a general challenges in Mozambique in general. And also there is a limited public-private engagement and oversight, mainly oversight of the private sector by the public. So, I mean, generally they don't even have much visibility, or they are not engaged with the private pharmacies. They don't know very well what's happening at the private pharmacies. There is also no aggregation body for the private health sector that results in fragmented interest and limited advocacy. So because they don't have this entity, I mean the private facilities, it's difficult for them to coordinate their needs and advocate for within the Ministry of Health to address their needs, and also their needs that might include, of course, collaboration and integration into the national health system. There is also limited pharmacy data collection and sharing through the National Health Information System. Next slide, please. Through the implementation of the MPHD project, we were able to facilitate the engagement in Nampula province. And I didn't say, but we worked in two districts, which is Nampula district at the capital, but also Nakala Porto. So together with the MOH colleagues at all levels, from central level to provincial level and district level, we worked with associations and private pharmacies and also clinicians, supporting supervision visits. We were able to advocate, and it's now a reality that the pharmacists, they are part of the monthly data analysis meeting at district level. Also, we were able to introduce, together always with MOH at all levels, we were able to introduce the standardized of quality of care practices approach for pharmacies. We provided what's this data recording and reporting tools, but also guidelines for family planning. We also were able to strengthen the capacity of the Association of Private Pharmacies, enhance the data collection and sharing system for the private sector. So now in Nampula, as a result of the MPHD project implementation, we have the the pharmacies reporting to the national HMIS, which is something good. And here we would like to say that this work of enhancing this data collection and sharing between the both systems, there is a work being done at national level to standardize and digitize tools for the private sector and to make it a nationwide use tools. Next slide, please. During the implementation, we saw that joint supportive supervision, including MOH representatives and private sector associations, it's important to change the regulatory framework. And despite the fact that this was not part of the project, we were able to perform supportive supervision visits, to perform trainings, and also introduce an approach for counseling called counseling for choice, which is something related to the project, but will be embraced by the MOH. But also we were able to enhance the referral system from the private to the public facilities. So this is also a reality. And it's also important to create a platform for public-private engagement on pharmacies So to be able to do this, it is important to engage with the associations of the pharmacies and regarding training and supervision, but also, as I said before, the private sector staff are now part of the discussions of the data analysis meeting discussion at these two districts that we implemented. And also the absence of a single private sector aggregator, different entities can play different roles. So it's important to engage with them and in all activities to give them the visibility, but mainly we are advocating for them to have like a secretariat at provincial level, because so far they only have that board at central level. So there is a need for them to have this entity in order to strengthen the coordination with the national, with the Minister of Health at all levels, mainly at provincial level, and be able to advocate for their needs and ensure they have a voice in the policy development. As I said, we also were able to provide guidelines, reporting tools, and they are now using these tools. These are the Ministry of Health standard tools for data collection and reporting. Next slide, please.
Elsa, if we can summarize, please, quickly.
Yes, yes, I think this is the last one with the lessons learned. So we learned that engaging pharmacies owners is crucial. And also it is important to strengthen public-private engagement to improve coordination. Integration of pharmacy service data into HMIS enables more targeted capacity strengthening and supports private facility. And this is one of the things that can help them advocate for policy development, because you need evidence to advocate for anything. So we still work with the national associations at all levels. Thank you so much. This is all that we have to share from Mozambique.
Thank you so much, Elsa. Quickly jumping into the next presentation, Wanjiru, please take us through.
Great, thank you so much, Farhan. So as for the topic of today, I'll be just quickly going through how private pharmacies have been participating in providing FP and RH services at the last mile. And just a quick overview of who InSupply is. So my name is Wanjiru Munene, Senior Advisor, Market Access and Shipping. I work for InSupply Health, which is a local affiliate of JSI. We have about 4 domains that are currently implementing various strategies and implementing projects: supply chain transformation, data transformation, intelligence and impact. I lead the market access shaping and the workforce optimization. So a lot of you who have interacted with InSupply would know that some of these domain names are new. It's just in line with our newly refreshed strategy, where we are aiming to be the leading health supply chain advisory firm in Kenya. Next slide, Farhan. So again, we work across both public and private sector. And of course, our focus today will be looking at how we've been engaging and how we've supported private sector pharmacies to participate in provision of quality family planning services and products, and also supporting various partners in the ecosystem with information, insights, and new product introduction strategies. Next slide. So this is just a quick highlight of some of the global goods that have emanated from some of our projects. And if you scan that QR code, of course, Farhan will show it also at the end of the session. It's just basically how we've been supporting healthcare professionals to upskill on supply chain management, including the private pharmacies, just looking at ensuring that they have the necessary commodities at their service delivery points. And this is also available to anyone who signs on and logs into the micro modules. Next slide. So InSupply currently has 3 key projects implementing access to family planning. These 3 projects are both in the public sector and private sector. Public sector in the sense that we support a lot of policy development, implementation, dissemination. We also support training of both public sector and private sector. And it's just recognizing that the private sector would not exist in isolation, given that there are various topics that have been alluded to by the previous presenters. So when you look at things like support supervision, when you look at mentorship, and when you look at guidance at the community level, we need to make sure that the private sector and the public sector are both aware of especially new products. And in this case, I'm referring to DMPAC. So we have the Injectable Success Collaborative, which has been very instrumental in developing the various policies and just taking up the high impact practices as introduced at the beginning and enabling that environment for Kenya. It has worked very closely with other partners in the ecosystem to make sure that we have the necessary policy, and the pharmacies are also given the agency to participate in expanded roles when we refer to reproductive health and family planning. So the National Family Planning Guidelines were updated in 2018 to allow pharmacists to provide injectables at the community pharmacy channel. And beyond that, then we started looking at how do we develop curricula that will help to upskill in-service, but also pre-service pharmacies. And beyond that, it's also looking at how can we create support supervision frameworks to ensure that the products and services being provided at the community level are of approved quality or standard quality. So market test and optimizing the pharmacy channel is purely focused on the pharmacy channel aspect of increasing access of injectables and other short-term active methods, including implants. So implants is mainly at the feasibility study. So we'll be also learning from what Nigeria and other countries have done in terms of giving agency to pharmacies to also provide implants. But marketers have been looking at what is the incentive for the pharmacists to participate in providing increased access of family planning, including counseling, which takes time, but also understanding what are the key levers or what are the key enablers for the client to accept to access some of these family planning methods from the pharmacy channel, given that traditionally a lot of these services and products were provided through the public sector healthcare facilities, and they were provided at no fee, given that family planning is a national program that is mainly donor funded. Next slide. So just in terms of the critical key stakeholders that we've been working with to support the community pharmacies to increase access to family planning through the pharmacy channel. Number one, as I alluded to, was the Ministry of Health, so looking at policies, rules and regulations, guidelines. But beyond the Ministry of Health at the national level, we also have the regulator. So community private sector pharmacies are regulated, approved, licensed by the Pharmacy and Poisons Board, which is the pharmacy regulator in the country. Also, a unique situation for Kenya is the Pharmacy and Poisons Board being a regulator, regulates both product and practice. And so it has been very instrumental in making sure that the pharmacies are approved and designated when they are trained. So designating pharmacies that have been trained, supporting them to differentiate from other community pharmacies, perhaps that have no familiarity in providing the expanded family planning products and services. Professional associations, we have two, just as it has been mentioned also in Nigeria. We do have the Pharmaceutical Society of Kenya, which is the association affiliated with Bachelor of Pharmacy graduates. And then we have the Kenya Pharmaceutical Association, which is an affiliation for people who have been trained on diploma in pharmacy. So they're essentially like pharmacy assistants or basically pharmaceutical technologists. So those two associations have been very instrumental in our implementation and in our scale-up in terms of supporting pharmacists to provide expanded family planning services and methods, but also supporting with counseling for clients. Traditionally, it was a lot of dispensing of condoms and pills, but now we are looking at injectables like DMPIM and DMPAC. And beyond that, it's also being able to counsel across all the relevant methods and being able to to refer appropriately if they cannot provide, for example, the long-acting reversible contraceptive. County governments have also been very key, and again, this is essentially for supporting scale-up of training. So we've got master TOTs and TOTs at the county level. At the same time, they also provide practicum sites, so they enable that system and network for the pharmacies once they have been trained on the theory to have facilities or points of care where they can go and practice and get mentorship and support supervision. But they also provide support supervision directly at the facility. They also support with product in case we have product gaps. So like currently in Kenya and a lot of other countries, we've had challenges with private sector channel DMPAC. So in the meantime, or as a stopgap, a lot of the county governments have agreed or made arrangements with the pharmacies to provide them with a public procured product, just to continue increasing service delivery through the pharmacy channel, community pharmacy channel, but also to continue sensitizing and creating awareness that the pharmacy channel is a point of care or a service delivery point where you can access injectables, as well as where you can be cancelled on different methods. Next slide.
Wanjiru, in the interest of time, I think you've spoken about a lot of the things in your initial slides. If you can just finish in, we want to leave some discussion time as well. So just quickly, I think you've already said a lot of these things. So maybe a minute to just summarize.
Thank you. Thank you for looking at my slides way in advance. I'll just focus on the challenges in this slide and then I will close. So in the previous slide. Yeah, so some of the challenges that we've seen is even with the policies, the guidelines, the enabling environment that has been developed and created together with the Ministry of Health, we still have a huge challenge when it comes to dissemination of policy, creating awareness of what the pharmacists can do. So as much as we try to create information through the professional associations, through webinars, through continuous medical education, we still have gaps in terms of pharmacists knowing that some of these guidelines have been updated and they can participate in increasing access for family planning methods through the community pharmacy channel. We've had shortages, as I intimated. The private sector importer distributor there's been a huge gap when it comes to specifically DMPAC. But of course, for DMPIM, we have different brands being distributed by different social marketing organizations. So for this, I'm speaking specifically for DMPAC, but also we see a challenge when it comes to implants as well, because implants are mainly procured in the public sector channel. So we've seen that the training aspect has been very expensive, resource intensive, but also time consuming, considering that you're asking community pharmacists to sit in a classroom for about 3 to 5 days to be able to upskill and to learn how to provide injectables and to also clearly understand how to counsel clients and ensure that they communicate choice. The other thing is that these pharmacies have to be designated with safe spaces so that they can provide privacy, discreetness when it comes to counseling and discussing the different various options for family planning with the clients in a very dignified manner. So those are some of the challenges that we've experienced through our implementation. Of course, some of the others would be issues about data reporting, and it has been great to learn from other countries how they've managed to perhaps circumnavigate those challenges in terms of using the community health information system. Yeah, so
thank you, Anjir. I think in the interest of time, we'll just have to move to the discussion, but we'll share these slides and we'll leave your context, and hopefully we can even continue discussing in the discussion. So sorry.
No problem. Thank you, Farhan.
Okay. Thank you so much to all our presenters. We understand, timing is always a challenge, but we do want to try and, allow some time for discussion so that, people can also synthesize what they are hearing, and it's not just about, the presentation. So thank you everyone for trying your best to keeping within our time. So I would like to first start off by allowing, I know there's a lot of discussion going on in the chat, which is great. Is there anyone who wants to come off mute and share some reflection, question, thoughts that they may have? Please feel free to raise your hand or just come off mute.
Hi, Farhan.
Hey, Dan.
I've just got something to flag for the community of practice, which is that last week Tanzania had its total market approach national forum, and is looking to revive its total market approach work. Since the end of Shops Plus, it hasn't really had a home. So I just wanted to flag to people in the room to be aware of that. I don't have anything specific beyond that.
Okay, thank you so much for that, Dan, and it's definitely noted. Yeah, and we'll discuss with the team.
Yeah,
Yes, Andy.
Farhan, hi. I'm just going to come off mute. And first of all, a big thanks to the presenters. And there is a lot to unpack. And I am going to reinforce this point that we are serious about time limits because we want discussion. So we really are trying to set that. And a huge thanks to everyone who helped meet those time limits. One thing in particular I'd like to highlight because it really gets at one of the things we're hoping out of this Healthy Markets community practice, and that is to prompt follow-on and joint efforts together. And to that point, I want to go back to the point of the high impact practices for pharmacies and drug shops, and noting a comment that Megan Christofield made in the chat. Thank you, Megan. This idea of, all right, that the high impact practices for pharmacies and drug shops may be on a regular set schedule for updating. But when we have a discussion like this, it may prompt a number of ideas about what needs to be updated. So I would just want to kind of put a flag in this of this might be a really good topic for people to come together and generate ideas about what should be revisited in an updating of the high impact practices. So I would also, I guess, sort of make a call out to people in the chat that if you have ideas and interests to just contribute to, what that might look like in terms of issues to consider. I think this is exactly the kind of follow-on that we want to see. Thanks. And back to you, Farhan.
Thank you so much, Andrea. Definitely well noted. And yes, as Megan has mentioned, there's already an email that has been sent out. I saw it come in as we are having discussion. So great. These are the kind of actions that we are looking for. Anyone else who wants to come off mute and share their thoughts? It's always nice to hear other people's voices. So, do any one of the presenters want to come off mute and respond to some of their questions perhaps that they are seeing on the chat? Sometimes typing can be a challenge. Any one of the presenters?
Farhan, I didn't present or anything, but I jumped
Yeah,
in.
sure, Ben. Sure, Ben.
What is it? I abhor a vacuum here when we get onto calls. It's kind of hard to resist not saying something. But the comment, Dan, your comment earlier about DKT and an analysis of the regulatory environment for advertising in Kenya is kind of making me wonder what else we could be doing more systematically as a community of practice to understand the demand side. I feel like the supply side of this equation has been, continues to be unpacked in very thorough and very nuanced ways, and that's appreciated. The demand side elements to this have been looked at in different ways on a kind of a project or an initiative basis, thinking about particular strategies. We've, over the years unpacked SBC or vouchers. Somebody mentioned IEC materials. More systematically, what does it mean from a commercial perspective to support or understand anyway the opportunities for marketing and advertising to effectively support commercial businesses. And it'd be great to see more of that explored in the context of this community practice. So more comment than a question, but just wanted to appreciate some of the activity here in the chat channel. Thanks.
Thanks, Ben.
Thank you so much, Ben. Yeah, go on, Ben.
I was say, it's really coming more from DKT than it was from me. It was a slide that Mary Aitken had presented, and what it showed was their sales in Tanzania, Uganda, and Kenya. And then on the side, it showed Uganda growing much, much faster than the other two countries. And on the side, it said, guess which country has legalized advertising for some family planning products. So that was the slide that I'm referring to.
Okay, great, thanks.
Thank you, Dan. Emeka, I saw your hand go up. Please, if you want to respond to any of the questions in the chat, please go ahead.
Yeah, thanks, Farhan. The project director for Integrate E project, I didn't present, but Mike did. But essentially, just to respond to you on the question around the tiered accreditation. The whole essence of the tiered accreditation is some kind of equity model, trying to use already existing human resources that are in the private sector to scale family planning services. So these are people that either would have worked in public health facilities as nurses, CHUs, or community health extension workers, but they now retired and set up PPMVs. So those skills that were acquired are already still there. So all that the project did was to be able to identify them, working with the provider, and then provided family planning training so that within the context of the PPMV, they can still provide some, limited family planning services. So it's not like it's disorganizing the market, so to speak, but to say these are resources that are already existing. How best can the country still utilize them when they have left active service in the public sector? Over.
Thank you so much, Emeka. I mean, the reason why I asked that question, and this somehow relates also to, I think, which was in the momentum presentation, right? Or in another presentation. I think, for example, in Tanzania, one of the challenges that we see is that there is a lot of resistance in allowing, let's say, drug shops that we call ADOs, accredited drug dispensing ADOs, outlets, because, the pharmacy association feels like you're giving them too much power or too much ability. And so how does that then relate to a pharmacy? Sometimes even the medical associations will tell you that, you know what, you are turning these drug shops and pharmacies into hospitals, or you're turning them into facilities. So I do know, and that's why I think I had noted somewhere that even professional associations of other cadres sometimes play a role in, blocking some of these things, and having such a complex sort of model of PPMVs, does it incite more fear in the other cadres? So just food for thought, not necessarily, I know we may not have time to discuss. Wanjiru, yes?
Yeah, I just want to respond to perhaps Rebecca, and also just to piggyback on what Ben was saying. So the issue about supply chain and demand creation, unfortunately, it's an egg and hen situation. It's an egg and chicken situation, right? We've been doing a lot of work creating demand, and then eventually the pharmacies are looking for the product and they can't get it. And one of the key challenges or key issues that we hear from the pharmacies is that they cannot introduce a new product to clients if they are not assured of the supply chain or the value chain. So they shy away from introducing the MPAC more and more. So in terms of how do we still keep the skill with the pharmacies, I think one of the things that we've been doing as part of our project is just having at least monthly touch points with those pharmacies. So we have almost like medical sales representatives that visit them, provide them medical information, but also provide them with bottlenecks, unlocking the bottlenecks. Like as I said, if we can't find the product in the private sector channel, then we try to link them to public sector so that there is continued service provision to the clients. And then, of course, I totally agree in terms of pharmacies being very strategic, and it would be very opportunistic to drive the aspect of self-care and self-injection because they are very accessible to clients. They access their clients even through digital platforms. I know we've worked with Ben Bellows, with Nivi, but also basic platforms and apps like WhatsApp. So clients are able to reach out to their pharmacists, ask questions, but also pharmacists are able to provide them, for example, with instructional videos through WhatsApp on how they can self-inject also as refresher points. So yeah, thank you.
Okay, we are 1 minute to time. Any last thoughts from anyone? If not, I know Andrea has asked the question in the chat. Andrea, do you want to also come off mute and ask that? And give your closing remarks.
Okay, yeah, sure. Thanks everyone. A number of really good points, and like Ben Bellows, you raised this, this question around advertising, right? And I think this is the kind of example that I feel we would all benefit from more detailed conversation about when we talk about policies and rules and regulations. It relates to demand generation, and it relates to what providers are licensed and trained to do. And so this is the kind of thing that we're hoping to really facilitate in this. And so I guess the question is, maybe people can just put it in the chat or reach out to Farhan, like, would it be valuable to have a follow-on session that's again about pharmacies and drug shops, where again we stay pretty focused so that we can start to do some follow-on work and dig deep, but at the same time have breadth across countries. So again, just a big thanks to everyone, and Farhan, back to you.
Thank you so much, Andrea. So yes, thank you so much. This was, I think, one of our most active sessions of the year. Clearly, there's a lot of interest in this particular topic. It was unfortunately our last session for this particular year, but thank you so much, especially for those of our regulars who've probably been through all the sessions throughout the year. We really enjoy all the participation, all the discussions. And yes, as we are ending the year, please feel free to send us your thoughts, suggestions on how we can improve the sessions more in the coming year. 2025, we are already thinking about doing more thematic sessions and, thinking about how we make this community of practice more action oriented. So thank you so much. We will be sharing a newsletter of summarizing this session today, and it will probably present a little bit of a teaser of what we are planning to do for 2025. So thank you so much, everyone. And yes, and thank you so much to our speakers for presenting today. Great presentations. So yeah, thank you all. See you in the new year.
Thank you. Happy New Year.
Thanks a lot.
Thank you.